Hello, dear friends. Welcome to Pulmonology Read Aloud. My name is Dr. Anshum Arora, and as discussed in the previous talk, this is the series on Gina Guidelines 2023, chapter wise. So, today we're going to talk about and read aloud chapter 2, which talks about assessment of asthma. The chapter 2 of 2023 GINA guidelines talks about asthma assessment. It mentions that whenever we assess a patient for asthma, we would like to look at three main issues. One is the control of asthma symptoms, two is the treatment related issues, and three is to assess comorbidities. By doing that, not only we check for symptoms in the patient, we're also trying to troubleshoot any problems that may arise during the treatment. So, the first domain of asthma assessment is to check the level of asthma control. Now, the level of asthma control basically means those manifestations of asthma which will be observed in a patient who already had symptoms and have now been reduced or removed by treatment. So the patient used to complain of cough and is better, or the patient was breathless and is better, or the number of exacerbations are better. So, what is the level of the control of his symptoms after treatment? And since it's determined by interaction of a lot of circumstances like the patient's genetic background, the underlying process of the disease, the treatment that they are taking, the environment, so it may keep on changing, and symptom control forms the first part of it. So we must assess the patient by asking him about his symptoms. The second part of this domain is the future risk of adverse outcomes. So when we check for level of asthma control, we have to check what will be his risk of poor outcomes in the future. And for all of this, although questionnaires are important, there's also a special mention that lung function assessment always remains a very important part of assessment for especially the future risk of poor outcome. So it's well defined in the guideline that lung function assessment must be done in accordance with the symptom control of the patient also at three levels. One is when you start the treatment, if possible. Two is after 3 to 6 months of the treatment to basically identify what is his personal best out of that exacerbation. And three is periodically thereafter. Now, asthma control prescription differs from patient to patient, and so Gina tries to identify the problems that may arise by inadequately describing the patient's level of asthma control. And they've given two very good examples which I wanted to include in this talk. The first one is that Mr. X has good asthma symptom control, but she's at increased risk of future exacerbation because she has had a severe exacerbation last year. So, whenever we assess a patient for asthma control, we need to see everything together, the risk of future episodes as well as the symptoms right now. Another example that they've given is that Mr. Y has poor asthma symptom control. He also has several additional risk factors for future exacerbation, which include a low lung function. So, here, lung function assessment is helping us, current smoking, and poor medication adherence. So, level of asthma control is in totality not only his symptoms but also his future risk of adverse events. Now, assessment of asthma in children above 6 years as well as adults and adolescents can be done by dividing it into three main parts, as I said. Number one, the symptom control and future risk of outcomes. Two, the treatment issues. And three, the multi-morbidity or comorbidity issues. So, whenever we are checking the control, one, we have to ask the control over last 4 weeks before presentation. When we are asking about controls, we must also try to find out if there are any risk factors where this patient may fare poorly later, and we should try to measure the lung function, as I said. About assessment of treatment issues, we have to document where the patient is in its current treatment step. So, what kind of treatment he's taking and where is he right now? We have to recheck the inhaler technique, the adherence, and we have to make sure that the patient doesn't have side effects. We also have to make sure that we have a written action plan given to the patient according to the guideline, and ask about the patient's own perception of his medications, any side effects he feels, and what is his level of control according to him. By assessing multimorbidity, we want to rule out problems that can mimic asthma symptoms. So, rhinitis, sinusitis, a postnasal drip, gastroesophageal reflux, presence of obesity along with it, presence of snoring and sleep apnea, anxiety, depression. All of these can cause poor asthma control. So, whenever you assess the patient, you have to rule out these findings also. This is a table that they've given for symptom assessment, and this is not a new table. It's been in the Gina Guidelines for long. So I'll quickly describe it. So the symptom control can be checked as well controlled, partly controlled, and uncontrolled. The symptoms that we ask in the past 4 weeks are daytime symptoms more than twice a week, nighttime awakening, reliever therapy SABA more than twice a week, and any activity limitation. Now, saying SABA reliever will raise a lot of eyebrows because I know that we all know now that SABA relievers are no longer advised in asthma flowchart according to Gina. But we'll come to that part when we deal with that chapter. Yes, it is not advised, but it forms track 2, as you all know. But the Gina guidelines have retained this question in their symptom assessment, but have also added a note about it, which I'll just mention. So now if your patient has none of these daytime, nighttime symptoms, reliever use or activity limitation, he is supposed to be well controlled. If he has one or two out of it, we say that it's partly controlled. And if he has three or four out of these, we say that it is uncontrolled. Now, often the problem that it is that when we think about asthma control, we just think about these questions and we decide whether it's well controlled, partly controlled, or uncontrolled. But now you know that it's also, along with asthma symptom control, the other factors. Now, as I was saying, that frequency of reliever use of SABA has still been retained in this guideline in this box because we know that the higher average use of SABA over a year is associated with severe exacerbations, more risk of even mortality with more SABA use. So, but they have also clarified that because they are discouraging SABA, and we are asking patients to take ICS and LABA or ICS formoterol on as needed basis. So in the current times, how can you replace it? You can ask for as needed ICS formoterol use in the last 4 weeks. So if you ask them about the average frequency they use their ICS formoterol, you can replace this question with the SABA overuse question. Now coming to the tools that you can use to assess the asthma control. So one of the tool is this questionnaire that we've already discussed. Also, when we talk about this tool, we understand that we've also to talk about the risk factors and we have to measure his lung function. There are some other tools also that have been mentioned. The first of these is screening tools. So screening tools that can be used are of varied variety. I think that just like me, most of you would agree that asthma control test usually comes as our first asthma control tool that we all think of. But when you look deeper into the guidelines, you'll understand they've also recommended many other tools. So the first of the tool is a screening tool, which is primary asthma control screening tool. Most of these tools have equivalent results, but obviously different readings, but can be used interchangeably. This is a very simple tool that you can use in your practice by asking the patient in the last 4 months whether he's had symptoms, the daytime symptoms, the nighttime awakening, the chest tightness on waking up, which also corresponds to early morning awakening, difficulty in performing activities, so activity limitation in running, lifting heavy weights, as well as in moderate activities. Now, based on this, he has to tick whether it's never, less than once a week, more than once a week, or not sure. And based on it, we give him a symptom score. So, this is called a primary asthma control screening tool. Another tool that's been also mentioned is a very quick tool called the 30-second asthma test. The 30-second asthma test says, again, symptoms which are 3 or more times a week. So it tells us about the level of control of the patient. So do you cough, sneeze, have chestitis because of asthma 3 or more times a week? Yes or no? Do you cough, wheeze or chest tight, wake at night 1 or more times a week? Yes or no? Do you stop exercising because of your asthma? And this question is in the past 3 months. So long term control. And very important for children, do you ever miss school or do you ever miss work because of your asthma in the past 3 months? Again, signifying poorly controlled symptoms. And do you use your blue inhaler or the rescue more than 3 times a week? Except one dose a day for exercise. So they've specifically in this questionnaire, we are not counting the relievers which are used for exercise. And this is also very quick and good control test because it talks about not only exercise limitation, it talks about the how asthma is affecting his day-to-day activity and also his nighttime symptoms. So this can also be used in a quick OPD practice. Then, after these screening tools, there are certain tools which come under the category of categorical symptom control tools. Now, categorical symptom control tools include firstly the Royal College of Physicians tool, which has only 3 questions for asthma, and it is called the RCP3Q tool. Now, here in the last 1 month, we ask if he has difficulty sleeping, if he has symptoms during the day, and if the symptoms interfere through usual activity. So again, you see they are more or less similar. It's just that which one you use in your practice, and the patient has to answer yes or no. So this is a very easy to use tool, and you can expand this by asking them about the frequency again into once or twice a month or week or daily. Another useful tool that exists is called the Asthma APGAR tool. So each of these letters APGAR refers to the questions that we are asking. The first question is about activity. So it is A. Activities in the past 2 weeks affected by asthma. P is about presence of symptoms and requirement of a rescue inhaler, and both in the daytime as well as in the nighttime. G talks about those factors that makes it worse at night, and this is very specific because it also talks about allergens, cigarette smoke, cold. So basically we're trying to find out what affects the patient and whether he feels that he can avoid these symptoms. A is asthma medications. So he has to list the medications in the past 2 weeks, whether he takes it daily or as needed, why does he take it, why does he not take it. And R, when I use my asthma inhaler, do I feel worse, no different, little bit, or better? So this one has been further advanced into APGAR plus score. And when you see APGAR plus score, so the APGAR stays same. APGAR stands for activity, persistence, the triggers or G, A or the asthma medications, R or the response to therapy. Right? So APGAR and plus. Plus refers to asthma plan. Does he have a written asthma plan? L, lung function. U, use of inhaler. And S, steroids. So I think APGAR plus core is a very good tool that we can use in our practice also. And by remembering the acronym of APGAR and plus, you can remember this score and you can ask about again activities, persistent symptoms in day and night, G for triggers and all the allergens and other things that can affect him, A for his asthma medications, and R for response, whether he feels is controlled or not controlled, along with the plus component. So these are some tools that can be used. Now, APGAR plus and asthma APGAR has its own interpretation also. And when you use this, you can use this interpretation as in if the patient has asthma APGAR score plus the plus also more than 2 are positive, you have to find out why it is positive. What are the reasons? Is he not taking inhaler properly? You should attempt to solve this problem. If he's still not responding, you recheck. And if it's still too high, then you reassess your diagnosis. But if your asthma APGAR and APGAR plus is less than 2, you correct the basic things and you step him down if he's better and you call him for a revisit. So these are very good tools. Coming to the tool that we already all know of, asthma control test, I think it's one of the most commonly used ones. This comes under the category of numerical asthma control tools because here we are trying to achieve a number. We are not just giving it a category, we are achieving a number. So here we've all used this. It talks about last 4 weeks. Again, it talks about symptoms at work. It talks about shortness of breath in the daytime. It talks about nighttime. It also talks about rescue use, and it talks about asthma control overall received. So most of them are almost similar. The problem with numerical control tools is ideally you have to take author permissions from them. Also, there are cutoff points which you have to remember to distinguish whether this is controlled or not. But these tools are generally more sensitive than the categorical tools. They're also more research oriented, and so these are used mostly in all research projects. So, for example, in the asthma control, the cutoff is 5 to 25 is the range. If the patient scores 20 to 25, he's well controlled. If the patient scores 16 to 19, he's not controlled. And if he scores less than 15, it's poorly controlled. But again, remember that a good symptom control can also have a risk of future exacerbation. He may still have a lot of risk factors that you should modify so that he doesn't have a severe episode. So that comes together when you're using assessment of asthma control. This is the other questionnaire, the asthma control questionnaire. It's heavily used in all asthma studies. This score is a more comprehensive score, and it talks about several grades of never, hardly ever, few times, several times, many times, great time, and unable to do that function because of asthma. Here the scores are 0 to 6, the higher the worse. Less than 0.75 is well controlled, and more than 1.5 is poorly controlled. There are a lot of variations to asthma control questionnaire. There are a lot of translations to this also. There's ACQ5, ACQ6, and ACQ7, which includes the reliever use, which includes exacerbation history. Gina Guidelines actually recommend the ACQ5 over the others. The one you see here is a 7 score questionnaire or tool. The other domain that I talked about when checking about assessing asthma control is the future risk of outcomes. And for future risk of adverse outcomes, we all know that it is exacerbations. So we have to define that this patient has uncontrolled symptoms and or the patient has a higher risk of exacerbations. So, what are the factors that increase the risk of exacerbation? If the patient doesn't have too much symptoms, so he has a good control, but the exacerbations risk is still high. The risk will be high if he is having a high SABA use. So, if he uses more than 3 times 200 dose canisters per year, along with increased risk of exacerbations, there is also an increased risk of mortality, especially if a patient uses more than 1 canister per month. So, if he's using such a high dose and that is why his symptoms are controlled, then he's at a risk of exacerbation. If he's not using ICS, then again he has a risk of exacerbation. Amongst medical conditions, if he has obesity, sinusitis, GERD, he has allergies, or in a pregnant female, there's more risk of exacerbation. In exposures, any patient who smokes, whether smoking or e-cigarettes, any patient who has a continued allergen exposure, and patients who are exposed to a lot of air pollution have more risk of exacerbations. We know depression is strongly related to asthma, so psychological factors affect exacerbation. When we check the lung function, the value of less than 60% of predicted is a high risk for exacerbation. Patients who have type 2 inflammatory markers like higher blood eosinophils or elevated FeNO are usually the ones who have more exacerbations. And if a patient has been intubated or required intensive care or more than one exacerbation in the last 1 year, then he is also at risk of future exacerbation. So that completes the assessment for future risk of adverse outcomes. There are also risk factors defined in the guideline which can lead to persistent airflow limitation. Now we know that in asthma there's a lot of variability and there is reversibility. An average FEV1 decline for a healthy non-smoker adult is to the tune of 15 to 20 mils per year. But you will see some asthmatics who have a consistent decline in lung function and a persistent decline, and they do not respond well to bronchodilators. Such patients may have a persistent airflow limitation. Who is more likely to have persistent airflow limitation? Those whose lungs did not develop completely. So they were preterm, they were low birth weight, or they did not have a good weight gain, or they had repeated infections in childhood which caused poor development of the lung, they will have more chance of persistent airflow limitation. Two, those patients who do not take ICS treatment and still they are having repeated exacerbations, they mainly depend on SABAs or LABAs, they will have persistent airflow limitation. Three, smokers and environmental smoke exposure will can cause airflow limitation which is persistent. And if you find very low FEV1s or patients who have eosinophilic types can land up into persistent airflow limitations. Now, the other factor that's important in assessment was the medication. So, we also have to remember that we have to ask our patient about medication side effects. We all know that most commonly patients will have local side effects which come because of not rinsing their mouth properly or following correct inhaler technique, which can result in thrush, which can result in dysphonia or change in voice. But there are systemic side effects, mainly in patients who are on frequent steroids orally, patients who are on long-term medication, high dose of inhaled steroids. These patients can have side effects of long-term steroids, which include bruising, which include osteoporosis, cataracts, glaucomas, and adrenal suppression. There are some drugs that have been mentioned in the statement which have interaction with ICS and the asthma medication. So we have to keep an eye on them. The cytochrome P450 inhibitors, especially the antifungals, antivirals, right, and clarithromycin. Also, they can cause more adrenal suppression and they can increase the cardiovascular side effects of the LABAs like salmeterol and vilanterol. Although vilanterol has been reported to be quite cardioselective and safe, but remember that if you have these drugs along, then the side effects can be higher. So we do not recommend LABAs like salmeterol and vilanterol to be given along with these drugs because although they are projected to be cardioselective, they can still have side effects with these drugs. Coming to the tools and extending them to the pediatric population, I'm sorry for this busy slide here, but this is from the guidelines. So I'll just quickly summarize it. There's a childhood specific asthma control test that can be done and a childhood specific asthma control questionnaire that can be done. But usually there are certain symptoms that we must ask as a part of assessment, which will include daytime symptoms of the child, nighttime awakenings of the child, and again, this can happen because of PND, this can happen because of GERD, so we make sure that we rule that out. The reliever use in the child, especially like pre-exercise or before playing sports, the level of activity. Does the child actively participate in his school activities or does he have to limit his activities because of asthma? Like adults, we want to rule out exacerbations, find out how many times does they affect them, does they interfere with his activity, does he have to miss school. The lung function, we have to check the curves, we make sure the technique is fine. It's difficult to do PFT less than spirometry less than 5 years, so oscillometry may be of great help here, which is although it has not been mentioned in the guideline statement. And the side effects, treatment factors, children, inhaler technique, very important to be checked. Adherence, check it with patients, parents, and the goals and concerns should be discussed with the parent or the caregiver. Children have a lot of allergies which you should rule out, and sometimes you can also give children the PEF monitoring, and a 2-week diary can be maintained where the PEF readings can be measured and entered, and the reliever use can be entered. There's also coming to the role of lung function in assessing asthma control. Gina again and again puts this point forward that the lung function test does not correlate strongly with symptoms. So do not use it as a replacement of asthma control because symptoms and lung function have to be measured independently, though low FEV1 is a risk factor for exacerbation. So we have to take care of it. And I've already discussed how frequently we should be doing a lung function. So how can we interpret the FEV1 values? Now, if the FEV1 values are lesser than 60%, I said the guidelines mention that there's more risk of exacerbations. Secondly, it also helps us to attend to the risk of decline in lung function further. So even if the patient does not have symptoms, we have to keep a watch that this patient may have a future rapid decline in lung function. And especially if your patient does not have symptoms, but the lung function value is coming low and patient denies having symptoms, it means that either your patient does not have a good perception of his symptoms or he has limited his lifestyle enough that he is asymptomatic despite a lung function decline. So these patients will require a closer watch because they are not perceiving their symptoms, so they may also react um, inadvertently to any exacerbation. So that's important. Secondly, if your patient has a normal or a near normal lung function, but he's symptomatic, that means you have to rule out alternate causes because maybe you're not dealing with asthma related symptoms here. Thirdly, if your patient has a persistent bronchodilator response, every time he comes to you, he is still showing a very good bronchodilator response, it tells us that his asthma is uncontrolled. So, this patient may require some further change in treatment because he's still responding to bronchodilators. So, for patients who are on regular ICS, when you see FEV1, and what will happen is you give him ICS, this patient's FEV1 is going to improve within the first few days, and usually by the 2 months it will plateau to the maximum best that will be achieved with that dose. Here it's important when we do the PFT again to document this patient's personal best, and we should ideally use this value as a comparison rather than his FEV1 predicted, because this is your patient's best value after regular ICS use. Now, if your patient on follow up shows a faster than average decline and he shows that this airflow limitation is not completely reversible, that means this patient may require a higher dose of medication. Sometimes he may require systemic steroids, or maybe this patient is the one you have to watch out for difficult to treat asthma. Thirdly, between inter visits. Now, if your patient's variability on lung function is very high, so if he comes to you and week to week the FEV1 varies by 12%, or between year to year there's a long variability, but the patient's symptoms are more or less same, then there is a chance that you may not be able to use the FEV1 alone as a marker of treatment change or adjustment because he has a very high variability. So you may not be able to trust FEV1 alone to make such decisions. Just like FEV1, if you when you would have listened to the first part of the chapter 1, PF monitoring also we know that can be used to assess the lung function of the patient. So here, what are the use of PF monitoring over short term and over long term? Short term, it gives us a lot of good information. So your patient comes in an exacerbation, you can give him a PF meter and that you can use to assess his treatment response, to evaluate triggers, especially in work related asthma or exposure related asthma, or to establish a baseline for his action plans, and then you can make an action plan for him. Again, just like FEV1, PF also improves once the treatment is modified, but it reaches an average of 2 weeks where his personal best is reached. Then it continues to increase, and in about 3 months, if the PF is not showing diurnal variability, then the patient's asthma is well controlled. Long term, we don't need to check PF for all patients. Long term assessment may be needed only for patients either who have severe asthma or where the group where you feel that patient did not show much symptoms but his lung function is poor. So you want to see what is the change because the patient does not perceive his symptoms very well. This brings us to the last part of the talk and the chapter, which talks about asthma severity. This will be dealt again later in the chapter on severe asthma. So I'm just giving a brief overview here. Asthma severity, according to Gina Guidelines, is a retrospective factor. To assess a patient of his asthma severity, whether it's mild or moderate or severe, you need to give him adequate treatment and then assess for response to see whether this patient is severe or not severe. So, we know the definitions. These are the definitions that are given. I don't want to elaborate on this right now, but you can keep a screenshot if you want. But the asthma severity assessment is based on a difficult to treat approach where we want to first find out if this patient is difficult to treat and then classify him further as severe or non severe asthma. So, talking about severe asthma and mild asthma and moderate asthma, severe asthma, the use of this term according to Gina, helps us to identify those patients who are difficult to treat first and foremost, and then address those issues and probably use further testings and phenotypic assessment. So it's important to define this after doing all of this workup. For mild asthma, Gina acknowledges that patients as well as physicians must remember that a mild asthmatic does not mean he does not have a risk of exacerbation or poor outcome. So, as much as possible, we should avoid the term mild asthma because there may be more exacerbation risk if the patient is on SABA alone, and its risk is going to be reduced by half to two-thirds if he takes low dose ICS. So, this has to be told to every patient that no matter your symptoms are mild or less frequent, you still have a high risk of exacerbation in the future. So, use of ICS is important rather than SABAs when that happens. Also, they've discouraged to use the terms that were used earlier called intermittent asthma, mild persistent asthma, moderate persistent asthma because they were arbitrary terms. They were not related to any outcome differences. So, they have now removed those terms and they are not to be used. The last part of this chapter talks about severe asthma. So, again, just to briefly touch upon it, any patient who has uncontrolled asthma with poor symptom control. So, if you remember the asthma control questions, so according to them, uncontrolled symptoms and frequent exacerbations which are requiring oral steroids or serious exacerbations requiring hospitalization will be called an uncontrolled asthmatic, out of which you will have either a difficult to treat asthmatic or a severe asthmatic. A difficult to treat asthma will be a big umbrella term, and here anybody who's uncontrolled despite medium to high dose ICS LABA or who requires higher dose to control treatment will come under difficult to treat group. A lot of these patients, you correct basic things like inhaler technique, adherence, smoking, comorbidities, they will be able to control. Some subset, a very minor subset of these, will be those who will still remain uncontrolled despite correcting all these problems, and they will be your severe asthma group. This is the flow chart, which I will again take up when I talk about severe asthma, and I do have a talk on severe asthma, so you can go through that talk as well. And that would make it clear how we approach a difficult to treat asthma, but this is beyond this chapter's purview. In the end, the chapter mentions what you should do with a patient who has poor asthma control. And as we've recurrently said, you have to watch the patient's inhaler, adherence, comorbidities, diagnosis confirmation, risk factors, consider treatment steps, step up. And if still that doesn't help, then maybe address those issues and think about severe asthma. So that concludes the chapter 2 of Gina Guidelines, which talks about asthma assessment. And it's an important chapter because it describes a lot of terminology and also gives us tools that we can use in clinical practice. I'll see you soon with chapter 3. Happy reading. Keep subscribing, sharing, and liking the channel. Thank you very much.